Okay.
Oh, no, maybe she's back. There she is.
Hello? Sorry,
Did
I
we
got
lose
kicked
you?
off again. Okay.
Oh, we just figured you were tired for the end of the day.
No, you know, the same thing happened to me yesterday. I got kicked off at the same exact time. So I'm glad it did not kick everyone else off. And we're ready when you are. I can do a brief introduction if you're ready.
I'm ready.
All right, perfect. So I think everybody can see me. They can hear me. All right, welcome back everybody from your brief break. Thank you for returning. This is our last speaker of the day, and then we will have some closing remarks, so please don't sign off too quickly. I want to introduce Dr. Robin Blitz. She's a board certified developmental pediatrician. Her clinical interests include medical home care for children with special health care needs, shared and supported decision-making, transition to adult care, autism spectrum disorder, Down syndrome, foster and adopted children, prenatal alcohol and drug exposure, ADHD, Fragile X syndrome, learning disabilities, premature infants, children with multiple developmental disabilities, and complex medical conditions and adverse childhood experiences. For 30 years, Dr. Blitz provided care for children with special healthcare needs, educated providers, students, and families, and directed patient-centered programs, such as the Down Syndrome Clinic at Phoenix Children's Hospital prior to joining United Healthcare. Dr. Blitz has been a medical director with the Special Needs Initiative of UHC for 3 years. As such, she works on behalf of children with special healthcare needs and their families since its inception. SNI has helped over 120,000 children and their families. So thank you so much for being here today, Dr. Blitz. Many of you may have had the opportunity of listening in on a past lecture, so we are happy to have her back.
Well, thank you so much, Teresa, and thank you and welcome everyone for staying till the end of the day. I was listening to that introduction and thinking about all of these interests, and all that means is that I'm really old and have been doing this for a long time. When I first moved to Arizona in 1996, I started working with the Phoenix Indian Medical Center and also started working with the state in children in foster care and their special needs, along with NICU follow-up and so many other things. It's been a long but wonderful journey, but I really appreciate being able to talk to everybody today, especially about this topic. So often first responders come across people with special needs and may not have the training, the knowledge, or the experience. So I hope this gives you a little taste and whet your appetite to learn more. And there we go. So I really don't have anything specifically to disclose other than I'm speaking as an individual person, and I need to say that my comments do not represent the policy or positions of United Healthcare, United Health Group, Optum, or any of its affiliated entities. That's the legal statement of the day. So these are some of our learning objectives. Listing 3 different ways that individuals with autism spectrum disorder communicate, listing 3 different ways that individuals with autism spectrum disorder express pain, and then identifying other medical, behavioral, or developmental disorders or disabilities that may impact the way that people interact with first responders. So first, we're going to talk about autism, and there is a good chunk of this talk that is about autism. Because I think that if we think about autism, learn about autism, and how to respond to people with autism, it can inform the way we think about other people with other disabilities, mental illness, and medical problems like dementia, for instance. So what you really need to know about autism: understand the unique needs of children and adults with autism, and learn how to recognize a person with autism, because there's no sign on anybody's head that says, "Hi, I have autism." You just might observe unusual behaviors that we'll talk about. So while I was preparing this talk, I also wanted to look a little bit at the literature, and I'm going to talk about the second article first. This second article that was published in October 2013 found that 13% of children with autism, and ASD is what I'm going to be using on the slides. Autism spectrum disorder is the formal term. So 13% of children with ASD or autism used at least one emergency service in a 2-month period. And unfortunately, sedation and restraints had to be used or were used 23% of the time. What the literature also finds is that when people have received ASD training and resources, it's associated with higher comfort levels, but not necessarily knowledge when people are tested. However, it was found that people with higher comfort levels actually did better with individuals with autism. That was more important than having the knowledge as shown on a test. They also found that younger and newer professionals had higher knowledge and higher comfort. So what is autism spectrum disorder? We know that in order to get diagnosed with autism, you have to have the onset of signs or symptoms before the age of 3 years, but sometimes it's not identified until later, especially for people that may have higher functioning. And when we say high functioning, we mean people that have some language, people that have average or above average IQs. We do know that people with ASD have a range of abilities and disabilities. So some people have intellectual disability and other people, as I said, have normal or above normal intelligence. There's a range of social impairments to those people who don't have any ability or desire to socialize, that child that you might see spinning in the corner, to the person who has higher functioning autism. We might have in the past called that person, said that that person might have had Asperger's syndrome. That person may want to have social interactions, but not know how. And then different types of unusual behaviors that we'll talk about in future slides, and different communication abilities, those who are completely nonverbal to those who might be hyperverbal, use a lot of words, but they don't always make sense, or they don't use verbalization for communication needs. We know that autism impairs and limits everyday functioning, and that it's a lifelong disability. So the DSM-5 was published now more than several years ago, and these are the criteria for ASD we'll review in the future slides, but it basically said that we're going to put together all these people, understanding that autism is a spectrum, understanding that autism is a spectrum from those who might have extreme abilities in some areas, and in the very old days, a person with those extreme abilities might be called an autistic savant, or high functioning autism, as I mentioned, or Asperger's, or another term that was used in the past was called pervasive developmental disorder, not otherwise specified, or PDD. To the person who has classic autism, where they also have significant intellectual disabilities and severe communication and social impairments, and significant repetitive behaviors, interest, and activities. So we now understand that it's a spectrum. Rett disorder or Rett syndrome is no longer included in DSM-5 because we know Rett syndrome is a genetic disability, a genetic abnormality that causes a specific phenotype. We also, as I said, Asperger disorder is no longer a specific entity in and of itself. And when they got together, the neurodevelopmental work group of the NIMH, they really felt that this spectrum disorder was a better reflection of understanding autism, that it would improve diagnosis without limiting sensitivity, that it would encourage earlier diagnosis, as DSM-4 was really focused on more school-age children. So let's talk about prevalence before we dive deeper into DSM-5. So the prevalence is now 1 in 54 8-year-old children in the US. And I just want to talk about this a little bit. In 2007 was the first CDC study that came out looking at these 8-year-old children across the country in 11 different sites. And in fact, Arizona is one of those sites that was studied. And in that first CDC study, they published 1 in 150 as the prevalence. And many of these people are now adults and many still need support and services. When they're looking at these 8-year-old children, they're looking at health records and school records when available. And so this 1 in 54 was just published in March of 2020, but it's data from those surveyed in 2016. And there is an increase, but it's really not known if the increases in ASD prevalence are partly attributable to a true increase in the risk of developing ASD or solely to changes in the community awareness and identification. So for instance, there has been an increase in screening and diagnosis in Hispanic and African American children, but it still varies by race, with white, Asians, and African American children still more commonly diagnosed than Hispanic and Native American children. Also, we're now using the DSM-5 criteria, as I mentioned, so it's more inclusive of PDD, NOS, and Asperger. The other thing that has been found in this prevalence study is that ASD prevalence varies among sites. So in Colorado, for instance, the prevalence is 13.1 per thousand, whereas in New Jersey, it's 31.4 per thousand. We also know that ASD diagnoses varies by socioeconomic status. The higher the socioeconomic status, the higher the prevalence. Now, we know that this has been consistent, that 4.3 times more, that it's 4.3 times more common in boys than in girls. Unfortunately, the median age of diagnosis is still over the age of 4, when in fact, the average age at which time parents have concerns is 18 months. So we still need to get better at earlier identification and diagnosis. About 33% of kids with ASD also have intellectual disability, 24% their IQ is in the borderline range, and about 42% have IQ scores in the average to above average range. That's an IQ over 85, which is significantly different than was recognized 20, 30, 40 years ago. So this is something that I think is very informative to me. This is the ASD prevalence on IEPs, or the school special education plans, per 10,000. And the blue line is ASD prevalence and you can see on the bottom it says the year 2000 and 2010. The green line is intellectual disability, which was formerly known as mental retardation. And I can tell you that this is definitely true, that in the past, we classified all children who were nonverbal as and different in their learning as mental retardation. Years and years ago, when I was in college and then medical school, I spent my summers as a counselor and then assistant director of a camp for girls with intellectual disability. It was a 6-week residential camp. There were 20 girls. It was not only about having camp fun with arts and crafts and swimming and hikes and bonfires and s'mores, but it was also about teaching life skills. And I can tell you, knowing what I now know today, that there was at least one girl and probably 2 who were misdiagnosed then with mental retardation, who, knowing that what I know now, those girls would have been diagnosed with autism. And one little girl specifically was nonverbal, had repetitive behaviors, had a lot of fears and anxieties, but she was smart as a whip when it came to figuring out puzzles and mechanical things and anything else that took visual motor skills. So I'm sure that if she was 10 years old now, she would have a diagnosis of autism, not intellectual disability. So here's the DSM-5 criteria that we're going to go over just to make sure that everybody's on the same page of what autism is by definition. And in order to meet criteria for autism, you have to have all three of the criteria that we'll talk about in the next slide that are under the heading deficits in social communication and social interaction. You have to have at least 2 of the 4 criteria under restrictive repetitive patterns of behaviors, interests, or activities. And the symptoms have to be present in early developmental period. But as I said, they might not become fully manifest until the social demands exceed the limited capacities that person may have. Or it may be masked by learned strategies in later life. Also, the symptoms have to cause clinically significant impairment in social, occupational, or other important areas of functioning. So what that means to me, and what I've shared with many parents over many years, that if it doesn't cause impairment, then it doesn't meet the level of definition of a disorder. And the disturbance is not better explained by intellectual disability, global developmental delay, or other mental illness. The other thing that DSM-5 came out and said is that now we understand that intellectual disability and autism spectrum disorder may co-occur and do so frequently. Remember, we talked about 43 or 44% of people with ASD have co-occurring intellectual disability. The other thing that came out with DSM-5 is that the providers are being asked to determine severity levels in each area, both social communication and restrictive repetitive behaviors. So level 1 means that a person requires some support. Level 3 means they require very substantial support, and level 2 is somewhere in the middle. And there are examples of this in DSM-5 if you're interested. So the first area, the deficits in social communication and social interaction. A person has to have all 3 of these. They have to have deficits in social emotional reciprocity. That means the give and take of social communication when 2 or more people are talking or communicating. The deficits in nonverbal communicative behaviors used for social interaction. That's your body language, that's your facial cues. You know, that's understanding that if a person has a furrowed brow, that they're thinking or they're stressed. Understanding that if a person's smiling, that they're happy and content versus a person frowning. Understanding that a person that's crying might be crying because they're sad or because they're tears of joy, and understanding the difference. And number 3 are problems developing and maintaining relationships, and this is important, appropriate to the developmental level. So we don't expect a 2-year-old to be playing duck, duck, goose, or to understand the rules of hide and go seek. But we would expect a 5-year-old to understand that. However, if a 5-year-old has the cognitive ability of a 2-year-old, we have to take that into consideration when we're evaluating the person. And then this, the restrictive repetitive patterns of behavior, interest, or activities. So remember, they have to have at least 2 of the 4 of these items. So they also, in DSM-5, we combined stereotyped or repetitive speech, motor movements, or use of an object. So classically, we might think of a person with autism having hand flapping, but not everybody that has autism flaps their hands. And not everybody who's flapping their hands has autism. A person might have repetitive speech, like saying the same word over and over, or use an object repetitively, like flipping a pen back and forth. The second area is excessive adherence to routines, ritualized patterns of verbal or nonverbal behavior, or excessive resistance to change. So if the parent says, we're going to go to Target, and then we're going to go to the bank, and then we're going to go to grandma's, but in between the bank and Target, the mom said, oh, I need to go to the grocery store and pick up an apple pie because grandma loves that. That child might have a tantrum because the mom went outside of the already planned routine. And that child might be very resistant to change. And I've actually had a patient a long time ago who the mom changed the route of going to grandma's because there was a detour. And so this child tried to get out of a moving car on the freeway. So some very dangerous things situations can occur because the child is not prepared for that change. Highly restricted fixated interests that are abnormal in intensity or focus. So it is typical of a 5-year-old boy, at least when my kids were 5, to love Thomas the Tank Engine. But it is not typical that everything has to be Thomas the Tank Engine. Thomas the Tank Engine games and television shows and pajamas and dishes and cups, or abnormality in focus. Abnormality in focus might be a patient of mine who was very interested in paper clips. And so he knew everything there was about the history of paper clips, that there were paper clips made out of rubber and plastic and metal, that there could be different shapes and sizes and colors of paper clips, and all his art was made out of paper clips. It was incredible art, and it's very interesting, but it is atypical and unusual. And then there's the hyper or hyposensitivity to sensory input or unusual interest in sensory aspects of the environment. Our kids might be hypersensitive to sound or light, or hyposensitive and not feel pain or a burning sensation. And I had a patient who actually had 2nd and 3rd degree burns because he did not feel the burning of his hand when he put it on an electric cooktop that was on. So the other thing I need to mention is that many of our kids and adults with autism have medical comorbidities that we need to be aware of and think about. 9 to 70% of people with autism have GI problems, and that might include selective eating or nutrition or constipation or abdominal pain or GERD, and that may be a cause of agitation. 11 to 39% have seizures. So when you see a person that may not be responding or have altered mental status, we have to think about whether or not that person had a seizure and is postictal. And of course, the management of seizures is the same. And then up to 80% of people with autism have sleep problems like restless sleep, insomnia, or obstructive sleep apnea. And that certainly can cause agitation or increased aggression or self-injurious behaviors. Our kids and adults with autism can have common illnesses, especially our kids with common childhood illnesses like ear infections, allergies, asthma. Dental problems could cause pain and agitation. Headaches could cause head banging because that person might not know how to deal with the pain in their head or communicate that they have pain in their head. Psychiatric comorbidities are common, like anxiety, ADHD, irritability, or aggression. And so we need to think about using behavior-based treatments as first line versus pharmacological restraints. And then it's always important to get a careful history of what's going on from the primary caregiver or the patient if they're verbal, so that you can best understand what's leading to this person who may look agitated or be aggressive or self-injurious. And then the other thing I wanted to point out that actually I learned more about when I started giving this type of presentation is that up to 17% of adolescents and adults with autism are at risk for having catatonia. And of course, we know that catatonia is a medical emergency that requires immediate diagnosis and treatment in a person with autism. And so We need to be aware of those signs and symptoms of decreased speech or mobility, freezing during actions, posturing, staring, negativism, or echo phenomena. And I'm sure that many of you are aware, and you've probably done this, that sometimes the use of a lorazepam challenge test is, oh, I'm so sorry, I forgot to turn off my ringer. I am so sorry about that. See what happens when you're a full-time telecommuter and you forget about these things? I apologize. There we go. Anyways, the lorazepam challenge test is given to a patient with monitoring for symptomatic improvement. And if there's no responses, you might know a second dose may be given. And then if catatonia is indeed confirmed, that person needs to be hospitalized for further lorazepam treatment or even ECT. The other thing I just wanted to mention is that mortality rates is significantly higher for adults with ASD, and sometimes as a result of their medical conditions, their GI problems, their respiratory illness, or epilepsy, and sometimes it's because they haven't been treated appropriately for their heart disease or diabetes or cancer. So why should we train first responders about ASD? Well, individuals with autism are 7 times more likely to come into contact with law enforcement than their neurotypical peers. And coupled with an autistic person's social differences and their inability to communicate effectively, these interactions can lead to misunderstandings or even tragedy. It's also important to know that approximately 35% of people with ASD have been the victim of a crime, and 23% may have interactions with police or first responders due to wandering or eloping, and we'll talk a little bit about that later as well. So a growing number of children with autism are now becoming adults, so it's really important that we in our whole community have a better understanding of this disorder and individuals with this disorder, as it's critical to helping them be safe in the community at large. And furthermore, as I mentioned, this training can pertain to others with different special healthcare needs. So we'll talk a little bit about why people with autism may be at higher risk for victimization and abuse, which they are. They're victims of fraud and theft and violence. And some of it is because they're taught compliance from the very beginning. They're taught not to question rules or people in charge. They're taught to be obedient and not assertive. They have decreased privacy. Think about all of these kids who've had early intervention and then have school interventions and continue behavioral therapy in their homes. And there's multiple adults going in and out of their homes all the time. They're also taught to be compliant, and that means agreeing with adults and authority figures. So they may readily admit to a crime that they didn't commit because A, they might not understand what's being asked for them, and B, they might think that that's what you want, and so they want to, that person may want to please you. Because autism is socially isolating, they may have less exposure to people who may be protective to them. We don't do a good job teaching about healthy sexuality and decision making. And also society has negative attitudes towards people with disabilities in general. People with autism may not recognize or respond to a uniform or a badge or an emergency vehicle appropriately. So you may need to point out your uniform or your badge and how you're there to be a helper. People with autism may be drawn to shiny objects like badges or guns, or be afraid of them, like lights and sirens. They may run towards or run away from police and first responders. They may avoid eye contact, so it's important not to insist on eye contact because that may increase anxiety and agitation. As I mentioned, They may exhibit repetitive sounds or emotions, so they might continue to do something even after being told to stop. And that may be a signal of distress, or maybe a way of self-soothing. A person rocking or spinning or bobbing their head might be self-soothing. So if it's not impairing, if it's not putting them in danger or putting someone else in danger, it should be okay to allow them to continue. And it's important to try and use non-threatening gestures and other ways of communication to help calm that person. If asked to provide an ID, that person may not understand what that means. It's always important to speak slowly and calmly. And some people with autism, their caregivers have put ID tags on their backpacks or on their clothing or on their shoes. There's actually shoe tags that go around shoelaces. Some people with autism actually might have tattoos that say, if I need help, please call my mom at, or might have special jewelry with that information on there. We talked about the fact that they may look like they're under the influence of drugs or alcohol, and remember that might be because they're actually post-ictal, so it's important not to make assumptions. And if you ask a person if they're on drugs, a person with autism, if they're on drugs, they might answer yes, because maybe they are taking medication and they don't know the difference between what you're implying when you actually are implying illicit drugs. They may become self-injurious. So it's important to use the least invasive technique to ensure their safety. Same with aggression. And I do want to just talk a little bit about restraints with if a person is aggressive or severely self-injurious. It might be much more beneficial to that person and to you as a provider to use a blanket and wrap a person tightly in the blanket like they're being swaddled instead of individual arm and leg restraints. Think about it. Blankets are softer in texture and may provide both temperature and tactile stimulation that is calming to that person. But it's not for everyone, so it's always important to discuss that with the caregiver. The other thing to know is that many people with autism may have low truncal tone and decreased upper body strength and upper body trunk area in general. And so putting a person in prone may actually cause positional asphyxia. And so I would encourage you to try other ways of helping to calm that person. It's always a good idea to try and find a secure, quiet place away from distractions, to interact in a smaller enclosed environment, and to try and de-escalate and distract. And one of the things is to also try and have less people interacting with that person and try and have the caregiver in there to be helpful. I want to talk for a minute about fire. So people with autism may not understand the danger that a fire presents and may re-enter a burning building, for instance, to get a special blanket. If there's a fire, if there's sirens going off and alarms and they're still in the home, they may actually hide in a closet or under the bed to escape the sound of the fire alert system or the sirens. They may have locked doors or windows that the caregiver has put on for safety. So it may be difficult to get them out of that environment. They may bolt if they're scared, and they may take longer to respond. They may not understand questions or have unusual pain responses, and that's in general. They may confuse pronouns. So if you say, "Are you scared?" they may not understand that you means them. And so that may be confusing to them. And people with autism often don't understand slang or idioms or sarcasm. So you need to be very clear on your communication. They may echo the question. Like if you say, "Are you okay?" instead of saying yes or no, that person may say, "Are you okay?" And so it's always better to give choices rather than yes or no questions. Let's talk a little bit about wandering and elopement. I think I said this statistic before, 23% of people with ASD may have interactions with police or first responders due to wandering or eloping. And eloping means wandering from a safe location. When they surveyed parents of kids with ASD, they found that children with ASD are more likely to wander than children with just other developmental disabilities than no autism. They found that children who have other mood disorders and anxiety and ADHD and oppositional behaviors on top of their ASD have a higher risk of wandering. And the lower the child's developmental level, the higher the risk as well. Now, when they, because of this wandering, because of elopement, they're at higher risk for injuries. And most of this elopement, 71% of elopements are eloping from the home. And 51% of these families have deadbolts or special door latches, 49%, and 6% of these kids have GPS systems on their tags, on their clothing, or on their wrists. These kids wander away and are often attracted to water and are at risk for drowning. And I think we have enough time, so I'll tell you a little story of one of my favorite patients. I know you're not supposed to have favorites, but I did. We're going to call him Joey. And Joey loved to swim and was actually a very good swimmer. And I knew this, and I actually knew where Joey lived because his brother played soccer with my son. And I also knew where my nanny lived. And I happened to know that my nanny and her parents lived in the house behind my patient and his family. One day, I got a frantic page from his mother because she couldn't find Joey anywhere. And she had told him that he had to clean his room before swimming, and that's what he wanted to do. But all the doors, the front door was locked, the backyard was enclosed with a tall wall. We live in Arizona, and he was not in their pool. At the same time, I got a frantic phone call from my old nanny's parents, and she was upset because there was a naked blonde boy in her pool swimming around, and she didn't know what to do. And so he fit the description of my patient. I called the mother back and said, don't worry, he's safe, and I know where he is, and this is the address. He's naked, you might want to bring a towel and some clothes. And I told my nanny's parents just to go outside and watch him. He's a good swimmer, he'll be fine, but she said, he won't answer me. And I'm like, he doesn't talk, it's fine. He has autism. So this little boy was safe, but this little boy climbed a 6-foot cinder block wall to go swimming because that is what he wanted to do, and dove into the pool from the top of that wall. So we have to be very mindful and watchful of our patients, our community members with autism, because it could be more dangerous than the situation that happened with my patient. And now we're going to go on to this video that I want you to watch, and I hope that sharing. Can you all hear it? Okay, let's go back to that. I hope you all heard that. The purpose for me showing this video, it's an old YouTube video. I've used it before, but for those of us who've never really experienced sound hypersensitivity, I thought it was a really good representation of what a person with sound sensitivity might be experiencing. Okay, so this leads us to talk about all of the sensory processing problems a person with autism might have. And this is important for first responders to understand to not only help understand what might be causing agitation or anxiety or fear for a person, but how to approach that person and what might need to be done to calm that person. We talked about the high pain tolerance or unusual response for hyposensitivities, but also I wanted to point out that we need to expect the unexpected, like ingestions. I had a patient who had a fascination with batteries and had swallowed multiple batteries. I had a patient who liked to eat orange rind and lemon rind, which we discovered was not really a big problem, but he was also eating the leaves of the plants, and there were some concerns that they had some poisonous plants in the backyard, so they needed to remove those plants. People with autism with tactile sensitivity might become really upset if they're touched. And so that makes it really hard to examine a person. So it's always a good idea to talk to the caregiver and find out what the best way would be to examine the person. And often it's to be calm and slow and start from distal, working your way up to proximal. And then remember that chaotic situations might be very difficult for that person, especially if they're in a stressful situation. So to try and make it as calming a situation as possible. And the other thing is we need to think about challenging behaviors. What do these challenging behaviors mean? And if we have time, we're going to go through some cases where I want to outline some of those challenging behaviors. But we need to always think about what is the significance of this behavior? Is the person in pain or upset or trying to self-soothe? What is the level of the person's verbal and social abilities? How do I best communicate with that person? How do I best interact with this person? And what calms the person versus what's the opposite effect? And what can be done to best facilitate the medical care of this patient? And so now we're going to switch to some of the other behavioral, developmental, and medical diseases and disorders that might be challenging or cause challenging situations in the situation in which a first responder might find him or herself. And we talked about how a lot of these ASD training materials might pertain to the approach, communication, and interaction with people with a variety of other disorders, like traumatic brain injury. People with traumatic brain injuries often have sensory hypersensitivities. Bright lights, strobing lights, loud noises might be very agitating to that person. People with cerebral palsy, intellectual disabilities, Down syndrome, Fragile X, Rett syndrome, people with Alzheimer's and other types of dementias, and people with mental illness are just a few to name. I do want to touch briefly about dementia and Alzheimer's. While I was researching for this talk, I learned that, you know, our medical services in the United States are helping us all live longer lives, and we've decreased the mortality rate associated with major diseases like stroke and heart disease and HIV. And the flip side of that is that as we get older, the more people have dementia, and the prevalence of dementia increases every year. And as it becomes more widespread, that means our communities need for our police, firefighters, EMS, and other first responders to have more training and understanding about these situations. So up to 70% of people with Alzheimer's are expected to wander, and Alzheimer's disease is the most common form of dementia. And one of the things that I learned is up to half of people with Alzheimer's who wander will die or sustain serious damage if they're not located in the first 24 hours. And the International Association of Chiefs of Police launched its Alzheimer's Initiative program in 2009 to prepare law enforcement for calls involving people with dementia. And they co-developed this ACP's Alzheimer's Initiative with the IACP and the Department of Justice, the Bureau of Justice Assistance, and the Office of Justice Programs. And participants are taught how to interact with people with dementia and are provided best practices for responding to calls in which a person with dementia is missing. They offer 2 programs. There's a 1-day direct training program and a 2-day trainer program. There also is, you're probably all aware, because we have this in Arizona, of the Silver Alert. It's present in more than 40 states. New York is not one of them, I learned, which I thought was interesting. It's inspired by Amber Alert, and Silver Alert allows law enforcement to broadcast information to help locate seniors that went missing while operating a vehicle. There's also the NCC DP First Responder Dementia Training, and they offer 2 certification programs that train first responders for situations involving people with Alzheimer's and dementia. And I have a bunch of these in the resource section of this presentation. This is a screenshot that I took from the First Responders Alzheimer's Association, and it's a nice 1-pager on the quick tips for first responders that I thought was really helpful. Moving on to mental illness, again, preparing for this talk, I learned that 1 in 4 adults and 10 to 20% of children in the US at some point in their life will be diagnosed with a mental illness or behavioral health disorder. And mental illness are now more common than heart disease and cancer combined. And in this year of COVID, for instance, the prevalence of anxiety in the United States went from 6 to 8% to 32%. Certainly, COVID has really brought out significant behavioral health problems for both children and adults. Then there was a study published called The National Impact of Mental Health Disorder that found that approximately 5% of US residents have a serious mental illness, and 10 to 15% of people in jail have severe mental illness. An estimated 7% of police contacts in jurisdictions with 100,000 or more people involve mentally ill. And it was found in a 3-city study that 92% of patrol officers had at least one encounter with a person with mental illness in crisis in the past month, which I myself I had no idea it was that prevalent. And we know that first responders encounter people with mental illness in many different types of situations, in roles that include criminal offenders, disorderly persons, missing persons, complainants, victims, and persons in need of care. And according to one Texas study, the 5 most frequent scenarios were a family member, friend, or other concerned person called the police during a psychiatric for help during a psychiatric emergency of a person they knew, or a person with mental illness felt suicidal and called the police for help, or police officers encounter a person with mental illness behaving inappropriately in public, or citizens call the police because they feel threatened by the unusual behavior or even just the presence of a person with mental illness, or a person with mental illness calls the police for help because of imagined threats. So there are training programs for people with mental illness, And there is something called Mental Health First Aid. It's a skills-based training course that teaches about mental illness and substance use issues. It's managed, operated, and disseminated by 3 national authorities: the National Council for Community Behavioral Health Care, the Maryland Department of Health and Mental Hygiene, and the Missouri Department of Mental Health. And more than 60,000 people have been trained in 43 states and Washington, D.C. Participants learn how to detect a number of mental illnesses, including schizophrenia, bipolar disorder, psychosis, substance use disorder, depression, anxiety, and eating disorders, and how to respond to people who have them. And this is one of their acronyms called ALGE, to remind you to assess for the risk of suicide harm, to listen non-judgmentally, to give reassurance and information, to encourage appropriate professional help, and encourage self-help and other support strategies. Also, there's CIT, which stands for Crisis Intervention Training, and it's a training program developed to help police officers respond appropriately to situations involving mental illness or developmental disability. And NAMI, the National Alliance on Mental Illness, helps support that as well. So just because we're heading into being done with time, and gosh, I'm sorry, this took longer than I thought. There is a law enforcement training bill. This will be in the PowerPoint that you will have access to. And Senator Bob Casey has introduced this to provide training for new and veteran law enforcement officers and enhance 211 regional networks rather than taking up 911 calls. This was a publication put out in 2008 to train people on how to respond, to train first responders on responding to people with ASD. And this is a nice acronym, CARES, that helps remind people the important things in interacting with a person with autism. And other important things that we've already talked about. And then if you're interested, again, this will be in the slide deck. This is a nice YouTube video that we don't have time to look at from the Hillsborough County in Tampa, Florida Sheriff's Office. They launched a program to help deputies better communicate with vulnerable populations. So we are not going to have time for all of our case presentations. I just wanted to, I'm just going to tell you about this one little guy. He was 5-year-old and nonverbal, and this is the actual, well, this is not the picture of the actual patient of mine, but I had this patient. He had a new self-injurious behavior of slamming into tables and desks, and there were no other changes in his family or school or social situations, no other signs or symptoms of illness, but this is what he was doing all day long. And when I asked the mom, when was the last time he went to the bathroom and had a bowel movement? And she said, I don't know. I've taught him how to be independent in dressing, toileting, and eating. And it turned out that he was, when I examined him, I could feel the stool in his abdomen, and he was incredibly constipated. And after a 3-day Miralax clean out, he stopped this new self-injurious behavior. He was trying to tell his mom and trying to tell me and anybody else who would listen, I need to poop. My stomach hurts, get it out of me. But he didn't know how to do it other than this self-injurious behavior. So he didn't need Risperdal. He didn't need more ABA therapy. He needed Miralax. So we're going to skip the other case reports for now. Just going to best practice. These are all the things that we just talked about. And the most important thing is to listen to the parents and patients' concerns or the caregiver concerns, because they are the experts and they can help you know what calms a person who might be in an agitated state. I have all kinds of resources and references for you that I hope are helpful. These are the trainings that I talked about. More information on medical home. This is preparing children for procedures from a national organization called Autism Speaks. And now I will stop talking, and I know that I've gone over time, and I greatly apologize.
No, you're good. We do have a few minutes still for questions, so Please type in your questions if you have any questions for Dr. Blitz. We have comments in the chat. Great information. Thank you. Now, somebody also mentioned I've recently done the mental health first aid program. It's excellent and well-rounded. People really enjoyed the life stories to learn from, and they will share the resources and references with staff. So any questions, just wonderful comments and feedback. As Dr. Blitz mentioned, the copy of the slides are posted on the website, so feel free to download those at names.org. I also posted the link earlier in the chat if you want the direct link. Question here, how is shutting the schools down affecting children with needs?
Well, it's been very hard, not only on the children, but also on their families, right? I mean, the parents who are supposed to be working from home, it's really difficult when they're also supposed to be teaching their children at school or at home, or helping their child stay online, and especially for kids with autism or other kids who just have the need for, I mean, kids with anxiety disorders also, who need the routine, or ADHD, routine and structure and sameness. It's been really difficult. So as I mentioned, the incidence and prevalence of anxiety has significantly increased, and especially in our kids with special needs, it's been difficult. And there's lots of listservs out there that talk about how they're just not gaining access to the same level of material. And I think all kids in general, their learning has suffered because of this pandemic. But for kids in special education who need that one-on-one assistance, it's been even more difficult for them.
Absolutely. Any other questions for Dr. Blitz? All right. Well, I don't see any other questions coming in. So thank you so much for being with us today. We really do appreciate all the information and your continued support in the NAMES Pediatric Symposium for past years as well. So thank you so much, Dr. Blitz.
My pleasure. And truly, if other questions come up, please shoot me an email. I'm happy to answer them by email.
Wonderful. Thank you so much.
So I'm supposed to go now, and you guys have your wrap-ups?
Yeah, or you can stay. You are welcome to stay. Stay, or you can leave.
Well,
we are just going to, yeah.
I'm going to go catch up on my emails, but I'm always happy to have further discussion. And, you know, maybe in future years, we might even, I was thinking about this, that might be really fascinating to have a panel that includes first responders, police, EMTs, others, and how they've dealt with different situations of children and adults with different special needs. So.
Absolutely. Thank you so much. That's a great idea. And hopefully next year we will be in person together. So that's a good segue into some of the next slides.
Well, President Biden was on earlier today saying that he thinks with Merck and Johnson & Johnson pairing up that we should all be able to be vaccinated by the end of May.
Oh, good. Yep. Well, thank you for the updates. That is great.
Thank you, everyone. Bye-bye.
Thank you. So with that, you can save the date for next year's symposium, February 28th and March 1st, in hopes that it will be in person at the Little America Hotel. I do want to ask you all again to take the survey at the, well, you can take the survey if you haven't completed it yet, or at least complete now the final speaker. The barcode is here. You can either use your phone and take a picture of that, or you can type in the Survey Monkey, and I can also put that in the chat as it's been in there previously. But we ask that you guys complete the survey. We will be looking at your attendance on Zoom to give you either the total of 5.25 CEs for today or 6.5 CEs for yesterday if you attended the entire one. If you did attend only certain portions, then it will we will give you as many hours based on your portion. So We really appreciate you all attending, and let me see if I can put this in the chat. And hopefully you all can see it. And just a couple other reminders as you guys do the survey, that names dues are being collected, and they are due by May 1st. So if you have not yet paid your dues, you can see on names.org. You can look under memberships if you paid them or not for 2021. Also, Vince had mentioned at the beginning, if you weren't here, that provider grants will be out in April. So please look out for those for Northern Arizona EMS. Remember to take your EMSC for Children survey as well if you have not done that yet. And as I mentioned before, a recording of this along with all the slides will also be on names.org in the next week or so. For your CE certificates, those will be emailed to you to the email that you registered on, or the person that sent your name if you were listening in a group. The certificates will all be sent via email. So hopefully we'll have those two in the next week or two, but please do be patient with us. So thank you all so much. If there are any final questions or concerns, feel free to type them in the QA or the chat, but you are free to go.